I would like to talk about the antibiotics that inhibit bacterial cell wall synthesis. So these are probably the most commonly used antibiotics. So we can divide the antibiotics that inhibit the bacterial cell wall synthesis into three main categories. Firstly, the penicillins, and then we have the cephalosporins, and we also have the miscellaneous ones. So miscellaneous ones such as carbapenems, azithromycins, and vancomycin. So penicillins, they are all derivatives of 6-amino-penicillinic acid, and they contain a beta-lactam ring structure, which is important for their antibacterial activity. So we can see that there is a side chain here. This is the typical structure of a penicillin. So we have the side chain here, and then we have a beta-lactam ring. So this square is called a beta-lactam ring. I don't know why. And then we have the thiazolidine ring. Okay, so we just have to focus mainly on the beta-lactam ring. So the subclasses of the penicillin group have additional chemical substituents that cause differences in the antimicrobial activity, and also the addition will cause difference in susceptibility to acid and the enzymes produced by the bacteria, and also it will also affect the pharmacokinetics of the penicillins. So it will affect the absorption, distribution, metabolism, and also elimination of the drug. So the pharmacokinetics of penicillins. Penicillins have different degrees of resistance to gastric acid. So the different degrees of resistance to the acid in the stomach will cause different oral bioavailability. And penicillins are polar compounds, meaning that they are very hydrophilic and not hydrophobic. So they are not extensively metabolized. So they are really easily dissolved in water. So they are not extensively metabolized due to the limited volume of distribution, the limited places that it can go because of its limited solubility in lipid compounds or in lipid. So penicillins are usually excreted unchanged in the urine via glomerular filtration and also tubular secretion. So this is a common MCQ question, whether penicillins are excreted through tubular secretion or is it through tubular reabsorption. So it's actually tubular secretion. So we can inhibit this process of secretion at the proximal convoluted tubules by giving probenecid. So if you give probenecid, you will inhibit the secretion of penicillin into the convoluted tubules, and this will cause the penicillin to be longer in the plasma. So you'll have a longer half-life of the penicillins, which can be beneficial. So the plasma half-life of penicillins vary from 30 to 60 minutes. And we have the procaine and benzathine penicillin G, which are given intramuscularly and have a long plasma half-life, as the active drug is released very slowly into the bloodstream. So most of the penicillins cross the blood-brain barrier only when the meninges are inflamed. So in normal situations when we don't have meningitis, so they will not go into the blood-brain barrier. So what is the mechanism of action and resistance of penicillin? So as we all know that penicillins are bactericidal, they kill the bacteria. And how do they inhibit the cell wall synthesis? So in the cytoplasmic membrane, so the drug, the antibiotic, the penicillin, will bind to specific enzymes called the penicillin binding proteins. So, and this will lead to inhibition of transpeptidation reaction, which involves the peptidoglycan chain in the cell wall of the bacteria, and they will also activate autolytic enzymes, which will cause lesions in the cell wall, so killing the bacteria. So hydrolysis of beta-lactam ring here. So when the bacteria release certain enzymes such as penicillinase that will hydrolyze the beta-lactam ring of the penicillin, this will lead to loss of antibacterial activity. So formation of beta-lactamases, example penicillinases. So beta-lactamases are enzymes that act on the beta-lactam ring. So we know that penicillins have beta-lactam ring, which is very important, central, fundamental for the action on the bacteria. So when bacteria will react to that, and they will produce beta-lactamases. And when they produce this, they will act on the beta-lactam ring and cause the bacteria to lose. So they lose their antibacterial activity. So formation of beta-lactamases by most staphylococci and many gram-negative bacteria is the main mechanism for resistance of bacteria to penicillins. And there are inhibitors of beta-lactamases, example clavulanic acid, sulbactam and tazobactam, are added to the penicillin for preventing inactivation by the beta-lactamases. So change of structure in target penicillin binding proteins has led to methicillin resistance in Staphylococcus and also penicillin G resistance in pneumococci. So this is another way how the penicillin, the bacteria produce resistance to penicillin by changing the structure in the target penicillin binding proteins. Thirdly, bacteria will change their porine structure, which is the outer cell wall membrane. So when they change this, this will cause difference, or this will alter the permeability of the cell wall membrane to antibiotics, and this will lead to resistance in some gram-negative rods. Example in Pseudomonas aeruginosa. So clinical uses: so penicillin G has a limited spectrum. They are susceptible to beta-lactamases, and they are used for streptococcal infection, meningococcal infection, gram-positive bacilli and spirochete infections. And many strains of pneumococci now resistant to penicillins, and most Staphylococcus aureus strains and a number of Neisseria gonorrhea strains are resistant via production of beta-lactamases. So the problem with antibiotics and bacteria is that bacteria are always evolving to fight the antibiotics. They are always evolving, they are changing the structures, etc. So that this will not be easy for antibiotics to kill them. So penicillin G is a drug of choice for syphilis, and it has activity also against enterococci. The activity against enterococci is enhanced by combination with aminoglycosides. So it's common for doctors when they treat an infection, they sometimes need to combine two types of antibiotics to to tackle the infection. So in this case, to kill the enterococci and to handle this kind of infections, you have to add aminoglycosides such as gentamicin to penicillin G. And penicillin V is oral, it's given orally, and it's mainly given for oropharyngeal infections, meaning infections in the mouth and also the pharynx. So methicillin, nafcillin and oxacillin are used in treatment of known or suspected staphylococcal infection. And MRSA, methicillin resistant Staphylococcus aureus, and also methicillin resistant Staphylococcus epidermidis. They are resistant to all penicillins and often resistant to multiple antibiotics. So these are one of the problems we have in the hospitals, where patients who will develop resistance to antibiotics, and when they develop resistance to penicillins, for example, they are usually also resistant to other antibiotics. So ampicillin and amoxicillin, they have a wider spectrum of activity against many bacteria compared to penicillin G, but the problem is that they are still susceptible to action by penicillinases, which will act on their beta-lactam rings. So the uses for ampicillin and amoxicillin are similar to penicillin G, plus they also cover enterococci infections, listeria, Escherichia coli, Proteus mirabilis, Haemophilus influenza, and also Moraxella catarrhalis infections. And activity against bacteria by these two penicillins, ampicillin and amoxicillin, will be enhanced when they are combined with penicillinase inhibitors, example clavulanic acid. So the famous example is augmentin. So we know that augmentin is actually a combination of amoxicillin and clavulanate potassium. So the clavulanate is given to handle or to act on the penicillinase. So when you inhibit the penicillinase, you will inhibit the action of the bacteria on the beta-lactam ring. So that will maintain the activity of the antibiotic against the because of the presence of the beta-lactam ring. So in enterococcal and listerial infections, ampicillin will act synergistically with aminoglycosides. Okay, piperacillin and tesarcillin also are penicillins, and they act against some gram-negative rods, including Pseudomonas, Enterobacter, and also some Klebsiella species. And these both piperacillin and tesarcillin, and they act synergistically with aminoglycosides against such bacteria. And they are susceptible to penicillinases, so that's the problem again. They are susceptible to penicillinases, and they are also often used with penicillinase inhibitors. So let's just go back to the slide on penicillinase inhibitors. So it could be clavulanic acid, sulbactam and tazobactam. So what are the adverse effects or unwanted effects that we might see from giving penicillins? So firstly, you have the main category is the allergic reactions. So you can have very severe pruritus, very itchy. Patients become very itchy, and then they develop a rash on the body, urticaria, and they might become febrile. They develop a fever. Sometimes they might develop joint swelling, and also hemolytic anemia. Their hemoglobin levels will go down because of destruction of the red blood cells, and then also nephritis, inflammation in the kidney, and also anaphylaxis, which is a life-threatening condition. So 5 to 10% of people with allergic history to penicillin will have another allergic reaction when given it again. So always be mindful of this. So 5 to 10% of people will have you give them penicillin. For example, you might give them penicillin V orally, and then when they come again the second time, they still develop. 5 to 10% of them will develop still another allergic reaction to the same antibiotic. Okay, ampicillin might cause interstitial nephritis, so involving the kidney, inflammation in the kidney, and then Penicillin will cause neutropenia, affecting the white blood cells will go down. And there's also take note that there is complete cross allergenicity between different penicillins, so we have to assume that there is complete cross allergenicity between different penicillins, meaning that if you give if you know that a patient is, for example, allergic to methicillin, you have to assume that the patient will develop the same allergic reaction to when given another penicillin, which, for example, Nephicillin. And ampicillins frequently cause a maculopapular rash, but this is probably not due to an allergic reaction. Oral penicillins, especially ampicillin, may cause nausea and diarrhea. And GI upsets, gastrointestinal problems, nausea, vomiting may be caused, or irritation may be caused by direct irritation or by overgrowth of gram-positive bacteria or yeast. And ampicillin is known to be able to lead to formation of the pseudomembrane in the large intestine, known as pseudomembranous colitis. So that's all for now for our antibiotics, specifically penicillin, and we will continue this video talking about cephalosporins in the next video. Okay, thank you.